Hyperthyroidism. So you must have studied in detail in your medicine regarding your hyperthyroidism. However, I'll be touching over some important surgical aspects from your hyperthyroidism. Now, first regarding your causes of hyperthyroidism. Now, it can be broadly classified into two groups as beautifully described in this table from the textbook of Sabiston. Now, one is your associated with normal or your elevated RAI uptake, and the second group is your associated with no or minimal RAI uptake. So what are your causes which is associated with your normal or elevated radioactive iodine uptake? Now first is your Graves disease. So this is the most important disease which I would want you all to know, and we'll be discussing a few important points subsequently. Then we have your toxic multinodular goiter, toxic adenoma, trophoblastic disease, TSH producing pituitary adenoma, and thyroid hormone resistance. Now, the causes that are associated with no or your minimal RAI uptake includes your painless thyroiditis, amiodarone induced thyroiditis, subacute thyroiditis, iatrogenic thyrotoxicosis, struma ovary, acute thyroiditis, palpation thyroiditis. Right, so I would want you all to remember this causes. Now the way the questions can be framed from this part is that they can actually ask you which of the following is the cause of hyperthyroidism which is associated with normal or elevated RAI uptake, all except, right? So hence the purpose to give this table, and you need to remember this table. Now a few important points regarding your Graves disease, right? So if you look at Graves disease, what are important points that you need to know? It is usually seen in young women, right? Then what it is? It is basically a diffuse vascular goiter. Now, eye signs are seen. Now, when we talk about eye signs, you need to note that the most common extra thyroid manifestation is actually your Graves orbitopathy, which is seen in around your 25% to 30% of subjects. Right. Now, another important question that is asked is that it has history of autoimmune disorder in approximately 55% of the patients. Then your diagnosis. Now this is a very trademark question that is asked from your Graves disease. So the diagnosis is by your thyroid receptor antibodies, right? So please do not make a confusion over here, because as we had discussed in your Hashimoto's disease, over there you have TPO antibodies, right? So just do not make a confusion between your Graves disease diagnosis and your Hashimoto's thyroiditis. Now apart from this, you can look at this image over here where you have your extrathyroidal manifestation. So if you look over here, this is your orbitopathy, which I have told you is actually your most common. Then you have over here your dermatopathy. Now what is dermatopathy? So what you see a pretibial myxedema, right? And then you have your acromegaly. Now the question that can be framed from this image is also a direct based question. Which of the following are your extrathyroidal manifestation of Graves disease, where you can have in options orbitopathy, acropathy, and dermatopathy? So the answer would be all of the above. Now regarding the treatment, right? So I've again simplified the treatment for you guys. What I've done is I have taken the table from your textbook of Sabiston. So over here we have your three treatment modalities, that is radioactive iodine, antithyroid drugs, and surgery. Now when to use what is beautifully described in this table. Now if you have your first as pregnancy, now you know in pregnancy radioactive treatment is contraindicated. So you have a cross for radioactive iodine treatment. Now antithyroid drugs may be given, and so is surgery. Then you have your comorbidities with increased surgical risk or limited life expectancy. So over there you can give your radioactive iodine, antithyroid drugs may be given, and you do not do any surgical intervention in such patient. Then you have your inactive Graves ophthalmopathy. So in that you can treat it with radioactive iodine or antithyroid drug or surgery. Then you have your active Graves ophthalmopathy. So what you do in active Graves ophthalmopathy is your antithyroid drugs and your surgery. Then you have your liver disease. In liver disease, you go for your radioactive iodine, right? Antithyroid drugs are not used and surgery is used, but then radioactive iodine would be a better treatment plan if the patient is having your liver disease. Now next we have your major adverse reactions to antithyroid drugs. So if there is a major adverse reaction to antithyroid drug, so definitely you are not going to give antithyroid drugs. Now over here the better treatment would be radioactive iodine compared to your surgery. Then patients which previously operated or externally irritated necks. Now, so over here again your better treatment option would be your radioactive iodine, and surgery usually does not have any role over here, and antithyroid medications may be tried. Now, if you have a lack of access to a high volume thyroid surgeon, so this automatically excludes your surgery, right? So you will go for a radioactive iodine and antithyroid drugs. Then patient with high likelihood of remission, especially women with mild disease, small goiters or negative or low titer thyroid receptor antibody, you will go for antithyroid drug which has a better response compared to your surgery and radioactive iodine. Then you have your patients with periodic paralysis. So again over here radioactive iodine and surgery has seen to have a good impact compared to your antithyroid drugs, which is also tried. Now patients with right pulmonary hypertension, congestive heart failure, again radioactive iodine would be a better treatment compared to antithyroid drugs, and over here surgery is usually not done. Then if you have your elderly with comorbidities, so again radioactive iodine or antithyroid drug, surgery is usually not done. Now in this three aspect, that is thyroid malignancy, one or more large thyroid nodules, and coexisting primary hyperparathyroidism requiring surgery, you would definitely go for surgery. So these are your some of the treatment options that would be needed in your Graves disease as per the clinical situation. Now when a question is being framed, look at this clinical situation clues which is going to help you to choose your correct treatment. Now I hope this table simplifies for you in order to solve your question, in order to select which treatment modality is required. Now apart from that, in your Graves disease you need to know about the preoperative preparation. Now preoperative preparation has few drugs, so let's discuss a few important points about those drugs. Regarding the mechanism of action and side effects have been dealt in your pharmacology section, so I won't go in details over here. So first we have your carbimazole. Now this is usually your drug of choice, right? Now what is the dose that is given? Dose that is given is around 30 to 40 milligram, right? Now this is given for around 8 to 12 weeks, which then renders the patient euthyroid, right? So if the question that is asked to you is could be in the form of that the patient is started on carbimazole, and then after what duration does the patient usually are rendered euthyroid, the answer would be your 8 to 12 weeks. Now once it is euthyroid, what we do is dose is reduced. Now what is the reduction down to? It is reduction down to 5 milligram 8 hourly, or you go for a block and replace regimen, right? So this is with respect to your carbimazole. Now you have another important drug which is your propranolol. Now again this is given 40 milligram thrice daily. Now this usually don't interfere with your thyroid hormone synthesis. Now, as a result of which, what is happening is that they can be continued in post-op period also for around 7 days. Now, they usually frame a question from here is that propranolol, which is used in preoperative preparation, needs to be stopped immediately in the post-op. No, my friends, it can be continued in your post-op period because it does not interfere with your thyroid hormone synthesis. Right. Now, another important aspect is regarding your ID. Now, it may be given 10 days pre-op. So if you have been in your surgical ward, you must have seen your residents or your seniors asking to get the patient iodine solution before the patient is posted for total thyroidectomy. Now, why iodine? It is seen to reduce the vascularity, and also it is seen to cause transient remission. Right, so hence iodine can be given 10 days pre-operatively. So this is a very important point regarding your pre-op preparation, where you use carbimazole, propranolol, and your IOD. Right, so this were your few important points with respect to your hyperthyroidism, where I have mainly covered the important surgical aspects, and the rest medicine aspects must have been dealt in your medicine section.